I'm Dr. Victoria, and this is George.
I'm Dr. Victoria, and today I am joined by a special guest, George's twin, Georgiana. Georgiana is newly pregnant, and we are going to go over what her office visits will look like during the first trimester of pregnancy. The first trimester consists of the first 12 weeks of pregnancy, and visits occur every 4 weeks. Once we have established that our patient is indeed pregnant, usually just with a urine beta HCG, we want them to come for a longer visit so we can get a good history and do a thorough exam. An important first question that will set the tone of the visit is knowing if this was a planned pregnancy and knowing what kind of support the patient has in their life. Once that has been established, we want to determine the due date next. We can use ultrasound results or one of the many calculators available using the patient's reported last menstrual period. One of these is Nagel's rule. You take the first day of the last menstrual period, add a year, subtract 3 months, and add 7 days. To establish an accurate estimated date of delivery, we want a fetal ultrasound done as early as possible so that we can compare that to our estimated date of delivery. Ideally, we want the ultrasound done before 14 weeks of gestation. It will be less accurate after 22 weeks. Ultrasound dating can be a better estimation of gestational age in comparison to menstrual dates if menses are irregular, the last period is unknown or uncertain, or if the patient has been taking oral contraceptive pills. It is important to know that any pertinent family history. This includes things like a history of family birth defects. We also want to know a patient's personal medical history. If any medical concerns were not optimized prior to pregnancy, it is important to do so now. We also want to know the patient's obstetric history. The gravity, this is the number of pregnancy including the current pregnancy. The parity, the number of carried pregnancies carried to a viable gestational age that is more than 24 weeks, and the number of abortions. This is the number of pregnancies lost for any reason. To communicate this, we'll write the gravity followed by the number of term births, premature births, abortions, and finally, living children. For the patient's gynecologic history, we'll want to know if she has been treated for any sexually transmitted infections in the past, and their menstrual history. That can be important for dating the pregnancy. Past medical history should be evaluated. Chronic problems like hypertension, diabetes, epilepsy, asthma, and mental health disorders like depression play a role in the pre, peri, and postpartum course of the pregnancy and may influence the risk of the pregnancy and medication selection that might be used for a possible induction. If the patient is on any medications, these should be evaluated for teratogenicity and safety in pregnancy. Now that Georgiana is pregnant, she's going to have to implement some lifestyle changes. This includes avoiding alcohol, having 300 milligrams or less of caffeine, that's about 3 cups. Caution at Starbucks, as some of those fancy drinks can have a great deal of caffeine, even if it's just 1 drink. Patients should also be counseled to avoid tobacco and illicit drugs. Dietary modifications include avoiding unpasteurized juices, cider, and milk, as well as soft cheese, undercooked meat, pre-cooked things like luncheon meats and hot dogs. Those should be reheated. What we're looking out for there is the cold, stable bacteria Listeria. Caution with fish as well. Different kinds can have varying amounts of mercury. And raw dough, those cookies should be baked. Patients should be on a prenatal vitamin if they're not already. The most important parts of the prenatal vitamin include folic acid for appropriate neural tube development, sufficient iron for oxygen transport, and, if available, DHA for brain development as well. This is just an omega-3 fatty acid, but because of the potential high mercury content in fish oil supplements, we might want to avoid those during pregnancy, depending on the brand. Other lifestyle interventions include always using a seatbelt, good for anyone, whether they're pregnant or not, avoiding hot tubs and saunas, and continued dental visits. We also want to screen for domestic abuse and barriers to consistent care, like financial constraints or rural living. We should also discuss what kind of work patients are in and if there are any work hazards that might be present, whether this is a chemical they might be exposed to or heavy lifting. Patients should be encouraged to exercise, but high-impact activities are not advised. No skydiving, scuba diving, and likely kickboxing is not the best option. Patients are usually interested to know what their weight gain goals should be for the pregnancy. For BMIs less than 18.5, there should be a 20 to 40 pound gain for the whole pregnancy. For a BMI of 18.5 to 24.5, women should gain about 25 to 35 pounds. For a BMI of 25 to 29.9, a gain of 15 to 25 pounds. And for BMIs greater than 30, there should be a gain of about 11 to 20 pounds. The initial visit should include a complete physical exam accompanied by laboratory examinations. This includes a CBC, CMP, urinalysis, urine culture, blood type and RH status, RPR for syphilis, rubella, varicella, chlamydia, gonorrhea, hepatitis B, HIV, potentially a pap smear, and evaluation of lead exposure. We want to screen for hypertension, thyroid disorders, or any genital issues. Depending on how far along the patient is, we may be able to check fundal height and check fetal heart rate, as well as monitoring mom's vitals and her symptoms of pregnancy. The fundal height is measured from the pubic symphysis to the top of the fundus. You want to palpate the abdomen starting at just below the xiphoid process and move your way down. You likely won't be able to feel the uterus too early on, especially palpating anteriorly, but you can still check for tenderness. For a Doppler exam, it'll take practice to differentiate the placental tones from the fetal heart rate. It'll be at least the 10th week before you can really find heart tones with a small Doppler. We'll want to check fundal height and heart rate at each visit. During the first trimester, we can evaluate for birth defects through multiple modalities. One of these is a nuchal translucency scan done with ultrasound to measure the fluid under the fetal neck at weeks 10 to 13. This, in combination with serum levels of pregnancy-associated plasma protein A and serum-free beta-HCG, show the risk of trisomies 13, 18, and 21, usually at 12 weeks, but as early as 10 weeks, cell-free DNA can be evaluated. This looks at fetal DNA within the mother's blood to demonstrate the risk of fetal aneuploidies. It's a little more challenging when mom is having twins or more, as it can be difficult differentiating the little bits of DNA which baby doesn't belong to. But exciting for the new parents is that they can know the gender as well with the cell-free DNA testing. Alternatively, there is quadruple screening in the second trimester, and gold standard testing is chorionic villus sampling between weeks 10 to 13 and amniocentesis in the second trimester with fetal karyotyping. We'll want to share warning signs for the patient to be on the lookout for during her pregnancy. This includes vaginal bleeding, significant pain, signs of a urinary tract infection, or a fever that is not responding to Tylenol. These are some of the topics I'll want to address with Georgiana during her first trimester visits. I know she is very excited to be pregnant, but a little bit nervous too. Thank you for joining me today, my healthcare team. I hope you'll join us next time as we find out what Georgiana, and his whole family get up to next. Bye-bye!